Hello, everyone. My name is Roland Veltkamp. I'm a professor of neurology at Imperial College London, and I'm also the chief investigator of a trial called Prevention of Stroke in Intracerebral Hemorrhage Survivors with Atrial Fibrillation, or shortly PRESTIGE-AF. Today, I want to give you some information on the background of this trial. First of all, of course, I want to give you a scientific update about the background of stroke prevention in ICH patients. And this will cover observational studies, smaller randomized controlled trials. I will also specifically address patients who are at higher risk of another intracerebral hemorrhage, such as those with lobar ICH or cerebral amyloid angiopathy. And I will briefly address left atrial appendage occlusion. In the remainder of my presentation, I will tell you about some basic facts about PRESTIGE-AF regarding study design and delivery. ICH survivors with AF are not a rare, but a very relevant problem. About 20 to 25% of all intracerebral hemorrhages are related to anticoagulant therapy. And the most frequent indication for oral anticoagulation in these patients is atrial fibrillation. You may know that the annual incidence of ICH related to oral anticoagulants is 0.5% to 1%. Every year, about 75,000 ICH survivors have an indication for oral anticoagulation in Europe and the United States. So the question for those patients is, they have atrial fibrillation, so they are at relatively high risk of having a thromboembolic event such as an ischemic stroke, but they're at the same time at a high risk of having another ICH. So we have to prevent at the same time ischemic and hemorrhagic strokes, and this can be a real dilemma. If we put patients on anticoagulants, we assume that their risk of another hemorrhage may be increased. And we know that the annual rate of ICH recurrence in patients who are orally anticoagulated after an ICH is somewhere between 2 and 8%. If we don't put them on oral anticoagulant medication, they are at increased risk of suffering an ischemic stroke, and these strokes are frequently particularly severe. And there's a wide range of risks, annual risks of ischemic strokes. I will come to that in a minute, somewhere between 1 and maybe 15%. For some time, a number of observational studies had been done. And in 2017, several groups, including ours, performed systematic reviews and meta-analyses on this topic. And what you see is the key result of one of these meta-analyses. On the left-hand panel, you see the rate ratio of ischemic stroke in patients who are anticoagulated. And this was mainly vitamin K antagonists versus no anticoagulation. And what you see is that the risk of an ischemic stroke was reduced by about 54% in those on anticoagulation. And this was statistically significant. On the other hand, the rate ratio for intracranial hemorrhage recurrence was slightly higher in patients who were anticoagulated. In fact, this was 23%, but this failed to be statistically significant. In conclusion, VKAs were associated with a lower rate of ischemic stroke compared to antiplatelets or no antithrombotics at all, but they did not seem to cause a major increase in risk of ICH recurrence. One of the studies that was included in this systematic review meta-analysis was done based on Danish registry data, and this included 1,750 intracranial hemorrhage survivors, and the investigators performed an analysis regarding the mortality rate. And what you can see in this Kaplan-Meier curve is that patients who were on oral anticoagulants, this is the top graph, had a significantly lower risk of death compared to those who were on antiplatelet therapy or no antithrombotic treatment at all. Now, clearly, these observational data have substantial limitations. They have a risk of confounding by indication. There is a risk of unmeasured selection bias. The populations included in these studies were heterogeneous, and there was limited information on underlying additional risk factors such as small vessel disease, blood pressure control, time and treatment range in patients who were on vitamin K antagonists and on concomitant medication. And so in this systematic review and meta-analysis, and in all other systematic reviews and meta-analyses, the authors concluded that a randomized controlled trial is needed to resolve the uncertainty regarding best management in patients with ICH and atrial fibrillation. Now, this is not just the view of the investigators doing these systematic reviews, but is also the view of experts of the European Stroke Organization that addressed this management issue at the latest Karolinska Stroke Update. And their recommendation was to enroll in randomized controlled trials investigating the optimal antithrombotic management after ICH very strongly. Now, so far I've informed you about observational data. Very recently, we have evidence from two smaller pilot randomized controlled trials, the SoSTART trial and the APACHE-AF trial. The SoSTART trial was performed in the United Kingdom. It was a randomized controlled open trial with a probe design. The follow-up of patients was done via questionnaires and sometimes GPs. It enrolled patients with spontaneous intracranial hemorrhage related to oral anticoagulants and atrial fibrillation. Patients were randomized 1-to-1 either to any oral anticoagulants or no oral anticoagulants. The study was divided into two phases. The first phase was a feasibility phase to assess the recruitment rate, and 60 participants were targeted in this phase. And the second phase included the patients of this first phase, and in total was aimed at 190 participants in the entire pilot phase. The goal of this phase was to determine whether the risk of recurrent symptomatic intracranial hemorrhage, this was the primary outcome, was sufficiently low to justify a definitive trial. And this was done at a 12% non-inferiority margin with a one-sided p of 0.025 and a power of 90%. This is the flow chart of the trial, and I would like to highlight one thing, that is a sub-study was done before randomization in which patients underwent brain MRI. And the follow-up was done for at least 1 year. These are the key results. On the left-hand side, you see the primary outcome, which is recurrent symptomatic spontaneous intracranial hemorrhage. You see that 8 patients in the anticoagulated arm suffered a recurrent intracranial hemorrhage, whereas only 4 in the avoid arm did. There were several secondary outcomes. For ischemic stroke, there were only 3 outcomes in the orally anticoagulated group compared to 19 in the avoid group. In terms of death from a non-vascular cause were more frequent, 14 patients, compared to the avoid group, 9 patients. If we look at the hazard ratios for the primary outcome, the unadjusted hazard ratio was 2.31, and this failed statistical significance in favor of avoiding oral anticoagulation. And for the composite secondary outcomes, there was there was a hazard ratio of around 0.5 in favor of anticoagulation for either any symptomatic major vascular event, any stroke or vascular death. All of these outcomes, again, failed statistical significance, though. The second trial was the APACHE-AF trial. Again, this was a randomized controlled trial with a probe design, which aimed to enroll up to 100 patients with orally anticoagulant-associated intracerebral hemorrhage and atrial fibrillation. These patients were started very early on the drug, 7 to 90 days after the index ICH. The comparison was between apixaban as anticoagulant versus no oral anticoagulant. The primary composite outcome was non-fatal stroke or vascular death for a minimum follow-up of 6 months. So these are the primary and secondary outcomes. The primary outcome was similarly frequent in patients on anticoagulant apixaban, 14 events versus 12 events in patients avoiding anticoagulation. In terms of the secondary outcomes, you see that the rate of major hemorrhagic events was about 2-fold higher in patients on apixaban, and the rate of intracerebral hemorrhage was 8% versus 2%. In terms of major occlusive events, the rates were higher in terms of patients who avoided anticoagulation, 22% versus 12% on apixaban, but similar rates for ischemic stroke, 12% in both groups. And the difference in terms of all major occlusive events was mainly caused by pulmonary embolism. So when we look at the hazard ratios for the primary and secondary outcome, we see that there is no statistically significant difference between the two groups, which was not really expected anyway, because this was a very small study. So what are the conclusions from both randomized controlled trials? Both studies did not show that starting oral anticoagulation is non-inferior to no anticoagulation regarding the risk of recurrent ICH. The SoSTART study suggests that starting oral anticoagulation may be superior regarding prevention of symptomatic major vascular events. And in fact, there may be a trade-off for fatal versus non-fatal events. Another outcome of the trials, which is important, is that phase 3 studies appear feasible. For example, SoSTART had a recruitment rate of 0.25 patients per site per month. And the recommendation of the chief investigators was that the best choice for patients after these 2 pilot trials is to recruit them into ongoing phase 3 randomized controlled trials. So I give you a list of these ongoing RZTs for anticoagulation in ICH and AF patients. The first 2 studies are APACHE-AF and SoSTART, which I briefly presented, and there are 4 ongoing other studies: the ENRICH-AF study, the ASPIRE study, the A3-ICH study, which in fact has 3 arms and also tests left atrial appendage occlusion, and the PRESTIGE-AF study. PRESTIGE-AF is planning to enroll up to 654 patients in 6 European countries, and it's funded by the European Commission. In the next part of my talk, I would like to address a particularly critical issue for these trials. And this is whether patients with a high risk of a recurrent ICH should be enrolled into PRESTIGE-AF or similar trials. And patients with a particularly high risk would be patients with a lobar ICH or patients with cerebral amyloid angiopathy. Now, the first thing, and I mentioned this before, is the risk of recurrent hemorrhage must, of course, be balanced against the risk of AF-related thromboembolism. Now, we are very familiar how we estimate this risk of thromboembolism using the CHATS2 VASC score that was introduced by Gregory Lipp one of the partner investigators in PRESTIGE-AF. In terms of the risk of recurrent ICH, this estimation is much more difficult, but we know from a previous systematic review and meta-analysis that the annual risk of recurrent ICH in all ICH patients is between 1.3% to 7.4%. The other important fact is that the annual risk of recurrent ICH after lobar ICH is 2 to 3-fold higher than after deep, or also called non-lobar ICH. Recently, population-based data from Oxford and from Scotland have addressed the risk of recurrent ICH, ischemic stroke, and serious vascular events after ICH. And I would just focus on two aspects. One is the location of the intracerebral hemorrhage, and the second is comorbid atrial fibrillation. So for these pooled data, if we compare lobar versus non-lobar ICH, and then the rate of recurrent ICH is again about 3-fold higher in this population-based data. In terms of patients with atrial fibrillation, this risk is very similar in both patients who have AF and who have no AF. The risk of ischemic stroke in all ICH patients, lobar versus non-lobar, is similar in lobar and non-lobar patients, 1.8 per year versus 1.6 per year. The rate of serious vascular events is somewhat higher. Now, this is, of course, much different for patients who have atrial fibrillation. In those with atrial fibrillation, your risk of ischemic stroke is 6.3% per year compared to no atrial fibrillation, 0.7% per year. And not quite as big a difference in terms of serious vascular events. The rate is 15.5% per year versus 6.8% per year in patients who have no AF. So the risk of recurrent ICH was greater than the risk of ischemic stroke only in patients with lobar ICH without atrial fibrillation. The risk of a serious vascular event was greater in patients with lobar ICH with comorbid AF compared to patients in sinus rhythm. So what is the effect of oral anticoagulations in patients with lobar ICH and cerebral amyloid angiopathy? And in fact, there's only one but very large study of observational data that gives us valuable information on this point. And I will go into a little bit of detail to inform you about this. So this was a pooled analysis of 3 databases, prospective observational studies: the German RETRACE study, the Massachusetts General Hospital ICH cohort, and the ERIC study, which was performed in several centers in the US. So to be enrolled in this study, so they had to have their no prior ICH. So this was the first ICH. And so they had to be on active oral anticoagulation for prevention of cardioembolic stroke due to previously diagnosed AF at the time of ICH. And they had to be alive and eligible for potential oral anticoagulant resumption. Then they were followed up 3, 6, and 12 months post-index ICH. The individual patient data meta-analysis included 1,012 ICH survivors with AF, and the investigators performed a propensity score matching analysis in which they adjusted for Glasgow Coma Scale, ICH volume, intraventricular hemorrhage, discharge modified ranking scale score, and CHATS-2 VASC score. And the outcomes that they looked at were mortality and disability, as well as ICH recurrence and ischemic stroke. Now, this is the key results regarding the comparison of patients with lobar versus non-lobar ICH. regarding mortality and for functional outcome. On the left-hand side, you see those with non-lobar ICH. On the right-hand, you see patients with lobar ICH, and you see the hazard ratio in terms of anticoagulation versus no anticoagulation. And what you see is in terms of mortality, this is 0.25 compared to no anticoagulation for non-lobar, and 0.29, so very similar for lobar ICH. And this was statistically significant. The chances of a better or more favorable outcome defined as a modified ranking scale score of 0 to 3 was more than 4-fold higher for non-lobar as well as for lobar ICH. The risk of recurrent ICH was slightly larger in both non-lobar and lobar ICH, but this failed to be statistically significant. And the risk of ischemic stroke, again, in both non-lobar ICH and lobar ICH, was reduced by 61 to 52% respectively. So overall, oral anticoagulation was beneficial for ICH patients with atrial fibrillation, irrespective of hematoma location, so also for patients with lobar ICH. The investigators did another analysis in patients with possible and probable cerebral amyloid angiopathy. And for this, they only chose patients for whom MRI data were available. These were 190 out of 379 lobar ICH survivors, so roughly 50%. And the diagnosis of possible or probable ICH was made in 136 versus 54 patients. What you see below are the hazard ratios, anticoagulation versus no anticoagulation resumption in terms of possible and probable cerebral amyloid angiopathy. The hazard ratio was 0.27 for possible cerebral amyloid angiopathy and 0.30 for probable cerebral amyloid angiopathy in favor of oral anticoagulation, and a favorable outcome MRS of 0 to 3. The hazard ratio was 3.40 and 3.11 respectively, again in favor of oral anticoagulation. So oral anticoagulation was associated with decreased mortality and favorable outcome in both possible and probable CAA. Now, a limitation of this study was that lower MRS scores at discharge for lobar ICH survivors who were started on oral anticoagulants were present. So this relatively large study had several strengths. It had included 3 cohorts. It was an individual level data analysis using suitable statistical techniques, including propensity score matching. Again, as a limitation, these studies were all observational. There was the risk of selection bias and confounding by indication. And the lack of randomization in oral anticoagulant resumption may have led to preferential assignment to oral anticoagulants of patients at higher likelihood to experience favorable outcome. And the conclusion of the investigators was, again, evidence from randomized controlled trials is needed. Now, again, we have some evidence from randomized controlled trials, albeit small. And so there is one of the supplementary analyses of APACHE-AF, which shows that in anticoagulated patients who had another ICH during follow-up, only 1 out of 5 ICHs were lobar, indicating that this is not very likely to be related in many cases to cerebral amyloid angiopathy. And for the SoSTART, I already mentioned the MRI sub-study, and of the included patients, about 1/3 of them had possible or probable cerebral amyloid angiopathy according to the modified Boston criteria. And there was enabled a comparison between patients who had 0 to 1 cerebral microbleeds versus those that had more than equal or more than 2 microbleeds. And what this shows is that patients with equal or more than 2 cerebral microbleeds had a similar rate of ICH recurrence in anticoagulated and non-anticoagulated patients. So the conclusions that I would make regarding anticoagulation after lobar ICH or cerebral amyloid angiopathy is, of course, lobar ICH and cerebral amyloid angiopathy carry a higher risk of recurrent ICH. Observational data suggests that the higher risk of hemorrhage may still be offset by prevention of thromboembolic events provided by oral anticoagulation, but the best choice for these patients is to enroll them into ongoing phase 3 RCTs such as PRESTIGE-AF. Now, I would like to emphasize why do we think that PRESTIGE-AF is a good choice, particularly for CAA patients. This is because the vision of our project is to really come to personalized decision-making for patients who are at such complex risks in different directions. And for that, we're collecting data on imaging, on biomarkers and genetics, and we will model the risks at the end of the trial. We are also looking at patient-centered aspects, which include the attitudes towards antithrombotics, and we also investigate gender-related aspects of CV trials such as PRESTIGE-AF. Now, there's already a very clear plan to not only analyze the data for the trials that I presented you with before, but there is a collaboration of controlled randomized trials of oral antithrombotic agents after intracranial hemorrhage, shortly COCKROACH. This is a prospective individual patient data meta-analysis of RCTs, and altogether these data will allow to answer many questions that in an individual trial will not have sufficient power to answer. Now, I would like to address an additional question which we are sometimes confronted with. This is the question whether patients, especially with lobar, but sometimes also with deep hemorrhages, or cerebral amyloid angiopathy should, rather than receiving oral anticoagulation, undergo left atrial appendage occlusion, briefly LAAO. Now, this is an open question right now, but clearly there's much more experience in stroke prevention in atrial fibrillation patients using oral anticoagulants. In terms of randomized controlled trials, about 50-fold more patients were enrolled in the NOAC trials compared to the left atrial appendage closure trials. And in reality, millions of patients have now been treated with NOACs, only thousands with left atrial appendage occlusion. Most of the randomized controls LAAO trials used vitamin K antagonists rather than NOAC as a control. It should be clear that after left atrial appendage occlusion, patients have to take antiplatelet therapy, and temporarily this is usually recommended as dual antiplatelet therapy. For the population that we are particularly addressing here, patients with previous intracerebral hemorrhage, the data on left atrial appendage occlusion are only observational and still very limited. Now, this is not meant to say that left atrial appendage occlusion is a bad procedure at all. However, at this point in time, it should be considered an experimental intervention that is being tested in ongoing randomized controlled trials such as stroke closure AF, and the A3-ICH trial. For the remainder of my presentation, I would like to familiarize you with some key aspects of PRESTIGE-AF in terms of study design and study delivery. The primary objective of PRESTIGE-AF is to determine whether direct oral anticoagulants compared to no anticoagulant therapy in patients with atrial fibrillation and a previous ICH can reduce the risk of ischemic stroke without increasing the risk of intracerebral hemorrhage. We have chosen the following inclusion criteria. Patients have to be older than 18 years. They have to provide informed consent, or if the patients lack the capacity to consent, this can be provided by an appropriate representative as defined in the study protocol. We only enroll patients with non-traumatic, spontaneous intracerebral hemorrhage, which occurred during the 12 months before enrollment. Patients can be randomized 14 days after the date of their ICH at the earliest. There has to be documented evidence of atrial fibrillation, and patients have to have a CHA2DS2-VASc score of equal or greater than 2 for male patients, or equal or greater than 3 for female patients. Routine brain imaging following the index ICH has to be available. In terms of key exclusion criteria, we do not enroll patients who are fully dependent, that is, they have a modified ranking scale score of 5. We do not enroll patients who are pregnant, breastfeeding, or planning on becoming pregnant, or who are unable or unwilling to take measures for effective contraception if they are still of childbearing potential. We do not enroll patients in whom ICH resulted from trauma or vascular malformation. Patients should not be enrolled if they have another indication for long-term anticoagulation than atrial fibrillation. Patients should not have hypertension, which in the opinion of the investigator is uncontrollable with medication, and any contraindication except for intracerebral hemorrhage to treatment with at least one of the DOACs that are considered investigational medical products in the trial. Patients should also not be enrolled if there is an absolute need for antiplatelet agents at the time of enrollment. We do not want to enroll patients who have already a left atrial appendage occluder in place, or where there is a plan to implant LAAO. If there is presence of any medical, psychological, or psychiatric condition which causes participation in the study to be unwise, patients should not be enrolled. And like in most trials, participation in any clinical study with an investigational medicinal product within the past 30 days of 5 half-lives of the study drug is not permitted. In terms of treatment options, we have a choice of 4 IMPs available: apixaban, dabigatran, edoxaban, or rivaroxaban, and the choice is at the investigator's discretion after talking to the patient. The dose must be the recommended dose for atrial fibrillation patients as per the SMPC. If participants develop the need to take antiplatelet agents during the study, this can be prescribed. The DOAC is provided by the pharmacy of Heidelberg University Hospital in Germany, and we recommend that the participant starts the IMP on the day of randomization or on the following morning if morning dosing is preferred. There are 2 treatment options. The second one is, of course, control group, and this means no anticoagulation. Antiplatelet therapy is permitted. It's not IMP, so it is just prescribed. The use of a single antiplatelet agent is permitted at the principal or co-investigator's discretion, who must check if there is an indication. We also allow the use of low-dose heparin for deep vein thrombosis prevention. I would like to give you a graphic overview of the PRESTIGE-AF study. So of course, the most important thing is to identify suitable patients who've had an ICH less than 12 months ago and who also suffer from atrial fibrillation. Patients are then approached and information is provided. In case patients are not able to provide consent themselves, this would be the representative. During the screening visits, patients would give informed consent and other screening procedures would happen. And then they would be entered into the screening log. If the patient meets all inclusion criteria and has none of the exclusion criteria, the patient will participate in an enrollment visit, and there the patient is randomized to either DOAC or no anticoagulation. And this can happen no earlier than 14 days after the intracerebral hemorrhage and up to a maximum of 12 months after the index event. Thereafter, patients undergo follow-up visits at 1, 6, 12, 24, and 36 months. Now we're specifically addressing collaborating sites to support recruitment. We would like to let you know that we allow randomization visits to occur off-site, and that delegated investigators may explain the trial to patients even by telephone or video call. Investigators can travel to complete the enrollment visit with the patient to another site where this is permitted by local regulations. We also allow follow-up visits at other hospitals remotely from the clinical trial site or at the participant's home, which means that participants who cannot travel to the PRESTIGE-AF site can still take part. If you are one of our collaborating sites, there are some do's and don'ts. We would very much appreciate if you could take the time to explain to suitable patients that the best stroke prevention treatment for intracerebral hemorrhage patients with atrial fibrillation is still unknown. If you would inform the patient that guidelines recommend enrollment into an RCT in this situation, that you inform your collaborating PRESTIGE-AF site about such potential participants, but of course only if they have given consent for you to do so. For you to arrange an online meeting for a PRESTIGE-AF investigator to discuss the trial with the patient, and to provide the patient with the local principal investigator's contact details if the patient agrees. You may also refer to the website, which is www.prestige-af.org for further information. Please do not obtain formal informed consent for PRESTIGE-AF from the participant unless you are a delegated investigator. Please do also not hand out the patient information sheet without involving the delegated investigator. Let me conclude. Optimal stroke prevention after ICH is currently unknown, as the risk of recurrent ICH has to be balanced against the risk of ischemic events. The effectiveness and safety of anticoagulation, and perhaps also left atrial appendage occlusion in this scenario, has to be carefully studied in adequately powered randomized controlled trials. Currently available data from observational studies and pilot RCTs do not provide sufficient evidence and conclude to enroll into RCTs. Expert recommendation from several organizations, including the European Stroke Organization, is that enrollment into RCTs is the best choice for stroke prevention in intracerebral hemorrhage patients with atrial fibrillation. So, in the interest of your ICH patients, please enroll them into PRESTIGE-AF. I thank you for your attention, and I look forward to working with you and your collaborating PRESTIGE-AF sites together on this important trial.